Hi, everyone, and welcome back to the podcast. And today we have a special guest on our podcast. She's a doctor, professor, and owner of Breaking Bad Debt, which is a social media platform which provides us with financial education and career advice. Thank you for coming on the podcast. How are you doing, Dr. Stephanie?
Great. It's great to chat with students in a more face-to-face setting. So it's always nice to kind of be able to meet who's in my classes, for example.
And it's really nice of you to be here with us today, Dr. Stephanie. We'll jump right into the questions.
Sure.
So what do you think most students get wrong about finance in medical school?
Yeah, I think the first misconception is that getting into medical school is the biggest hurdle. That, once you get in, it's like time to relax and YOLO and that you're set. It kind of reminds me of like that picture of, how like someone climbing the first mountain only to find there's like an even bigger mountain ahead. And the thing is, like, there isn't really anything that is set about medical school except your debt. And so there are uncertainties in like where you'll match, whether you'll match, how much things will cost, whether you'll get that financial aid or not. And there's a lot of things that you can't control in medical school. So you always want to think about what can you control, and the only thing you can control is yourself and how you choose to prioritize your things in your life. So if you kind of look to what other people are doing, you'll always find someone who might have more money than you, more connections, more publications, and etc. So it's always important to try to focus on yourself. And it's always better to overestimate than underestimate your spending, because you could very well end up in a situation where you can't control. So, you might go unmatched. So you want to be financially prepared. The second big misconception is that doctors are rich. Medicine is a very stable job, no doubt about it. But the reason why doctors can make high incomes is because they can also work long hours. So of course, like the more you work, the more you'll earn. However, doctors also do a lot of unpaid work that comes with either running a small business. They might be asked to join committees, attend conferences to maintain credits for their certification. And all of these things are not paid. So maybe on like a per hour basis, it might not be as much. And when you compare that to like a salary job, there could be benefits in the medical model in that if you want a raise, you just work more, although that could be detrimental to your physical and mental health. But the other thing to know about that is, that's different is if you want a promotion, like for example, you get promoted from assistant professor to associate professor, for example, like that actually does not come with a raise. And usually in industry, promotions do come with raises. And then I guess the third misconception that I thought about was the line of credit. Like a lot of students think that getting a line of credit means that the money is your money. And so students will think, oh, now I'm like $350,000 more richer than before. And so they might use their line of credit to gamble in things like cryptocurrency or whatever meme stock is in the news. And I remember someone in my class used their line of credit to finance new furniture for their condo. So what you have to know is that the line of credit is a callable debt, so that the bank can call the money back if, for example, you no longer meet the requirements of having that line of credit, like you're no longer enrolled as a student. So think about your line of credit the same way as if your parents gave you a loan and said it was to help you get through medical school. Like, of course, getting brand new furniture and getting cryptocurrency, it doesn't really have anything to do with your medical education. So I guess those are my big three misconceptions.
Yeah, that actually sort of spells out a lot of things for us students, especially the point about like line of credit. I feel like a lot of my peers sometimes talk about like investing using the line of credit, and like from what you've said, it's very clear that that's not very advised because obviously first it's not part of your medical school education, and second there's no way to sort of like repay because the stock market can be volatile at times. And if you have those like sort of liabilities that you purchased with your line of credit, that may result in you not being able to repay the bank when they ask you to. So I think that's a very, very fair point. And my next question will actually be geared towards a previous point you talked about, which is this myth that doctors are rich because they have so many other commitments. So my question to you is, could you explain to everyone how exactly doctors make money in Canada? So maybe more about the billing process or any information you feel is necessary to explain that.
Yeah, and this is like often very complicated. And I know that on my channel, I have done lectures, like a 5-part series about how to bill. But I'll try to briefly explain it. So most doctors in Canada make money through fee for service. So basically, it's self-explanatory. You see a patient and then you bill OHIP for that service, or bill whatever your Ministry of Health is in your province. And so what you make, or what you bill, is what you get, right? Minus any overhead that comes with running of the practice, like utilities, rent, staffing, and any sort of costs of the equipment, for example. So that's the overall gist of it. Now, in family medicine, it gets more complicated because family medicine, on one side of the spectrum, you have that fee-for-service model that you might see in like walk-in clinics or procedure-based clinics, like pain clinics, for instance. But then you also have something called a capitation model. And so family doctors in Ontario will be paid in the FO model, so Family Health Organization, which is a majority capitation model. What capitation means is basically each patient is kind of paid a subscription fee. The government pays a subscription fee that might range depending on someone's age, someone's sex, someone's complexity of their illnesses. So there's several factors that go into it. And so if it's an older person, female, maybe has a lot of conditions, they might get paid a bit more, and then someone younger might be paid less, for instance. And so it's kind of like when you see there's a lot of those like nurse practitioner run clinics that might charge, like, for example, $400 to $600 per year to have a medical subscription with that clinic. It's kind of the same way, but not at that level, right? It's more like a fourth or a half of that amount. So that's part of the reason why a lot of family doctors in Ontario specifically are having these issues with the billing model. So that's one end, right? And then people in that subscription or capitation-based model can also earn some fee for service, but a very much smaller amount. And then there might be some additional bonuses, for example, working evenings and weekends on that as well. And then right in the middle of when I say fee for service and FO, Family Health Organization, there's something called Family Health Group. And family doctors that work in a family health group kind of have a blend of both, with the majority of it being fee for service, and then maybe like 30% of it being capitation. So that's very complex, right, for a family doctor. And then finally, you also have salary. We see salary more so in specialties like pathology, for example. In some certain pediatric centers, they're paid in salary. And certain family doctors who work in community health centers are paid salary. So if you're paid salary, you can probably find out what the salaried person is making by going on the Sunshine List, for instance. And a salary is very simple. It's just like having any job in industry. You get a salary, you get health and dental benefits, you get EI, you get mat leave, things like that. Whereas the other models I've mentioned, you don't have those. And then finally, there's also AFP. So these like alternative funding plans. Sometimes you see those in like academic centers. Some emergency rooms have this. And this might be kind of like a blend of people getting grant money for research, but also they can bill fee for service as well. So I wouldn't go into too much detail about that because it varies so much across different academic centers. So hopefully that kind of gives you a little bit of a overview of the different types of billing models.
Yeah, it's very interesting. It's not something that we've gotten to know as we were applying to medical school or even in medicine. I think another aspect that comes with medicine is just all of the additional information that you need to learn outside of medicine. One of them being business knowledge, like you've mentioned, the multiple models. I want to ask, do you think it's necessary now at this point, for family doctors to be able to receive business training or some sort of mandatory training so that they feel more comfortable picking a specialty, knowing that there's a family doctor crisis currently going on in Canada?
Yeah, so I guess if you're asking whether like family doctors should also have business training, I definitely think there should be training on billing, like how the billing system works, because it is very complicated for some family doctors to learn, and then also practice efficiency and time management. Um, the reason I say those topics are really important is because not all doctors want to be business owners. Like, for example, if you're working as a pathologist, chances are you might be working a salaried model, you'll be working in a lab. So you're more likely to be, for example, an employee. There are some people who work in hospitals, in which case they're not exactly owning their own clinic or running their own business, right? They're kind of just independent contractors to the hospital. Usually the hospital might provide them with like ORs or maybe like a clinic space, and then they pay some overhead to the hospital. So that all being said is, should there, I guess if the question is, should there be like business training to family doctors? I feel like giving all family doctors business training may not exactly have the intended effect because it might actually deter family doctors from starting a family medicine clinic. So what I mean by this is, let's say I separate the fact that I'm a doctor myself, and I just look at a family medicine clinic purely from like an investor point of view. And then I analyze the clinic in the same way that you would analyze a business. So you might look at metrics like free cash flow, operating costs, growth trajectory of the business year over year, the management and the turnover of those working there. You might notice that maybe for a lot of family clinics, the cash flow would either be break even, maybe even negative. And usually if the cash flow is positive, then what that might mean is that the clinic owner is making a profit. And what it also might mean is that the overhead on the doctors might be higher, in which case you come across the challenge of a high human resource turnover because maybe the doctors will just leave to go somewhere else where the overhead might be none, like in a hospital, or lower. So that's kind of the challenge of the family medicine business model currently.
That's a very interesting way of looking at it, Dr. Stephanie, and I hadn't thought of it that way. So it was really interesting that you brought it up. I think it's also because I've been hearing a lot about family medicine, and a lot of people are saying that no one's really opening up solo clinics anymore, and that might be because of the reasons you highlighted.
Yeah,
And
precisely. Yeah.
yeah, and I understand what you're saying about the business education, because not everyone might want that, or like they just make a more informed decision after that. But just to get a basic knowledge in the field of business, what do you think are some books that everyone should read about personal finance and investing, or even courses that you've come across?
Yeah, so in terms of books, I remember I had made a video about this. I think it was called something like Top 5 Personal Finance Books to Help You Reach Financial Independence. And I try to focus only on like Canadian books because I have a largely Canadian audience. Maybe you can link that in the video description there, because those are kind of my recommendations for more technical financial content. But for more like, let's say if it's like mindset or like motivation on getting your finances in order, the books I liked are Die with Zero, The Millionaire Next Door. And I also liked biographies of people who have kind of found success in society despite being dealt like a bad set of cards in life. So one book that comes to mind is Where You Are Is Not Who You Are. It's a book by Ursula Burns, who is the first Black woman to lead a Fortune 500 company. So I think those are some examples of books that I personally like. You also asked about courses. So of course, I know I have a lot of my lectures on YouTube for free, and there is probably a lot of good content on YouTube as well. There's another course that I recommend to some students. It's like McGill Personal Finance Essentials. And that's another course people can look at, and it's taught by the profs from the DeSautel School of Business, and you can kind of check that out as well. Oh, and I was also going to mention they're free. Like personally, I try not to really recommend a lot of courses that are paid because they do charge quite a lot when there's so much like free resources in terms of books and free courses out there.
Yeah, I mean, it's quite counterintuitive since a lot of these courses can be paid because the course is about personal finance, but you're investing a lot into learning personal finance. So, at least monetarily speaking. So, yeah, that's a really great resources you pointed out. And obviously, I've noticed that on your Instagram, you do post regular book reviews. So I think that's a great resource for everyone to check out, and we'll also be plugging all of your socials in the description below for anyone who wants to check out Dr. Stephanie's content. And I guess, branching off of that, you have your YouTube channel, you have multiple successful social media platforms. My burning question is, what made you want to start it all? What made you want to start Breaking Bad Debt?
Yeah, I get that question a lot. So Breaking Bad Debt has both like an Instagram and a YouTube presence. I just never thought I would get into TikTok, so I didn't. And I guess they're gonna like, I don't know, whatever happening in the United States, they're probably like gonna cancel it altogether. But basically, there's this program at U of T Med that's called Community of Support. And kind of like the name suggests, it helps students get mentorship and research opportunities to introduce them to STEM fields, like to future medical students and scientists. So I initially started giving webinars to community of support students about affording medical school before giving like the whole class lectures that you guys attend. And someone had said about how they feel pressure to spend on expensive things because on Instagram, they see classmates or influencers who post pictures of themselves shopping at designer stores or buying expensive makeup, going to clubs and bars, and they felt like they had to do that as well in order to fit in. And they had thought about using their line of credit so that they can kind of get into the same social group as their classmates. So I started Breaking Bad Debt on Instagram first to kind of be like the anti-influencer. So I try to post stories of me going couponing. I had posts about shopping at thrift stores, working like side jobs as a resident. And then when I was a resident, I also kind of posted about my income and kind of my sources of side job income as well. And then as an early staff physician, I also try to show more income transparency, where I kind of showed like, oh, like month 1 to month 12 of being a staff physician, this is kind of how my income went up, how I was trying to work to be more efficient and how that impacted my income as well. So yeah, I guess there just wasn't a lot of that on Instagram. And then I started a YouTube channel in March of 2020. And so you might remember that's when the pandemic hit and everything went on Zoom. So that's when I sort of started having access to my financial lectures, whereas before I didn't really have access to them. And so now I was able to also give lectures at other schools as well. And so with those like recordings from Zoom, I just threw them up on YouTube because I thought it was like a good platform to make my lectures like open access so anyone can watch them. Like you don't have to be a tuition paying student to access it. I guess the other reason why I chose YouTube was because when I was going through the medical school application process myself, I think the whole reason why I did well on the MCAT or why I had like a good GPA in the first place is because of a YouTube channel called Khan Academy. And I'm not sure if it's like still something students use, but I think like because of that and that all these free resources on YouTube, I think that kind of saved my GPA and saved my MCAT score. So that's why I chose YouTube as the platform. So I guess, being kind of an introvert myself, just being able to do these lectures in front of a camera kind of helped me gain comfort in talking to larger crowds. And it also taught me how to build my teaching portfolio and my teaching ability as well.
Yeah, I think one thing that we thank you for is just how transparent you are with the entire process. And like you mentioned, in residency or taking a side job and showing exactly what you're making. I think that's one of the biggest learning tools that you can provide to the viewers. That's something that we can relate to as well. One of the biggest reasons we wanted to start MedBoys was because we realized that there wasn't enough information for Canadian medical schools. And since we were going through the same process, we kind of just compiled everything together. So we really appreciate that.
Yeah.
But now that we're talking about having a social media presence, I want to ask you how you're able to balance your career as a doctor and at the same time having a social media presence, and whether you think it's difficult.
Yeah, so the thing with my social media and YouTube, it's just something that I do and enjoy on the side. Like sometimes, I guess maybe in medicine, like we feel like we have to be productive in everything we do. Like we can't just read a book for fun. It has to be like, I don't know, a research paper or something. So for me, it's not like something I turned into a business where there are like regular uploading schedules, seeking out sponsorships, because then it would feel like it's a job. And I like to keep it as a hobby. I think it's important to sort of have those things that you still do in your life for fun, rather than thinking, oh, everything I do has to be monetized, has to have performance metrics. Like not everything has to be productive. And then also the social media content for me, a lot of it is financial. So, it's a little bit different than being like a medical influencer, for example. I think, if you're a doctor with a medical social media, it comes with more like scrutiny from the College of Physicians and Surgeons, and also from your hospital or clinic where you work, because what you can say online can directly impact your employer. And so, for example, at my hospital, we're required to report our social media accounts. And there are even rules around saying like that the opinions you post are your own and not that of the employer. So I guess because I don't take it so like seriously, that's why I don't feel like it's that hard. And I don't try to have to force myself to upload like every month. I kind of just upload whenever I do a lecture or I have some lecture recording from this talk I gave, and then I just put it up.
Mhm. And I can completely relate to what you're saying about everything having to have performance metrics, because it feels like when you're in medical school, you have like limited time, and then you're like, should I dedicate 2 hours of this to something that I don't know is not going to do well? And sometimes we feel ourselves fighting the same thing. Like we started MedBoys just as a podcast initially, where we're just talking to cool people like yourself. And then sometimes we get into the mindset where like, why aren't there enough views? Why aren't we doing well? And we have to stop ourselves at that point and realize that we're doing this for fun and as friends, because like we've known each other since we were in grade 9. So we've just been doing things together since then.
Yeah, and it's so important to like keep up friendships in medical school, because sometimes you're so busy like doing research and studying that you forget about friends, especially those friends who might not be in medicine, right? There's like a bubble. So I think if you're just doing it for fun, you are enjoying it, you like having that time to talk to cool people, then yeah, like by all means, just keep at it.
Yeah, definitely. And that's kind of the mindset we want going forward as well.
Yeah.
I have a question relating to that last question as well. Did your experience in finance specifically influence your decision to go into addictions medicine or family medicine, and how did that interplay with each other?
Yeah, so I have a kind of an interesting story in how I went into addiction medicine, because when I first started medical school, I was one of those people who didn't really know what a lot of things were. Like some people already knew what like plastic surgery was, what dermatology was. I was very clueless. I just knew there was such things like family doctors and like there are surgeons, but I didn't know the different types of surgery there are. So initially, I was interested in health of the homeless. So in U of T Med, there was this clinic called the Imagine Clinic, and basically it's like a clinic where for people who aren't going to U of T, they provide healthcare to people who are like refugees, people who don't have OHIP cards, and people who are homeless. So I would do that on my weekends. And then when I was a clerk, I started doing like health of the homeless electives with the Inner City Health Associates. In Hamilton, I went to do like Shelter Health Network electives as well. So I always figured like, I would go into something that can kind of work with people who are low income or who, don't have as much as we do, for example. So when I started doing, so during my medical school, I also did a master's, right? So as part of this master's, I was in business school and the School of Public Policy. So as part of that master's, we had to do some sort of consulting project with any sort of organization. And I chose to go to Boston Healthcare for the Homeless for like 3 to 4 months in my 4th year. And so when I went there, I was paired with a team that did addictions. And I was like, oh, I had no idea this actually existed. So what this team did was they provided addictions care in prisons, and they had this van that drove around at night to hand out things like safe injection supplies and things like that. And then it was also that at the same time as the Trump presidency, that was the first year. And I think it was at a time when, as a Canadian, if you're in Canada, you're watching all of these like Women's March and March for Our Lives, all of that kind of on the news. But when you were in the States, like me, you were actually in the middle of it, like you were living it. And so with a lot of the marches that were happening, I think I was also involved with like a medical care with March for Our Lives. So March for Our Lives started as a protest against school shootings. And it was really interesting because I got to see how my medical colleagues, those addictions doctors, they were really passionate about policy. They were really passionate about advocacy and about public safety. They also noticed that when I told them I was Canadian, some of them had said that, they had thought about coming to Canada and practicing here, just because the way that addictions are treated in Canada is a little bit different than how addictions might be treated in the States. And but then they ended up not coming to Canada, they ended up staying in the States because they didn't want to leave behind their patients. And I thought that a lot of the character of the folks I worked with who did addictions, it was very noble. And I really respected that. And so I discovered that in the States, to go into addictions, you would need 3 years of internal medicine residency, and then addictions were like a subspecialty, like you would apply to like cardiology or gastro, for example. And then in Canada, you could go into addictions through internal medicine, but most people go into addiction through family medicine. And that was probably the shortest path into addiction. You can also go into addiction through psychiatry as well. So I thought, okay, like, of course, I really like this field. And I really like the people who worked in it. I think they are wonderful, respectable people. And so I thought, okay, maybe I'll try for that. And so when I made my rank list, I tried to actually rank by geography and by what can get me into addictions faster. So right when the rank list was due, I happened to be in the United States at the time. And so I ranked it based on geography because my partner was kind of restricted in having to work in larger cities. And so I also ranked based on how can I get into addictions faster. So Toronto Family Medicine was my first choice. And then once I was in family medicine, I did a lot of selectives and electives in addictions. I basically worked in every single hospital that had some sort of addiction service as a selective or elective student. And then when I graduated family medicine, I just straight up went into doing addictions. And I didn't do a +1. Some people will do enhanced skills training like a +1. But I felt like given all of the experience that I gained during residency, I was pretty comfortable not doing the +1. And so I just went straight into working in that field without it. And I still keep my family practice. I still do it 2 days of the week, just because I think it's still nice to keep those skills. And a lot of my family practice, a lot of the patients don't speak English. A lot of them are immigrants. So I think it's really nice to still be able to kind of help out patients who, might not be able to navigate care because they have a language barrier, for example. So that's kind of my story of how I ended up in this. And then I guess you asked me whether finances influenced it. Not directly, but definitely indirectly in a way that family medicine is one of those specialties that are short. So you graduate and then you can start paying off your debt earlier. So it was in a way like one of my considerations. But I think for me, a lot of it was the people that I was working with. Like, do I like the people I was working with? And can I see myself doing this specialty every day? And whether it was something that allows me to be in a geographical location, like it had that flexibility to it. Yeah.
That's an amazing story, Dr. Stephanie. Thank you so much for sharing. And from sort of what I gathered, there seems to be like this sort of snowball effect where, you had a lot of, you kind of came into medical school not really knowing much about like the different types of specialties, and then you found something that you really resonated with. And it seems like you built across that throughout your entire career in medical school and residency, and then your practice as well. So I think it's a really great story. And I think that kind of is a great way to lead us to sort of the beginning for medical students, like the start of medical school, and sort of the decisions that people make when it comes to their specialty. A lot of medical students come in feeling very pressured to have that decision made right away. And, one factor that we feel like should be talked about more is, the employment factor, right? So we've personally been surprised when we found out that there were specialties in medicine that actually didn't really have many jobs available at the moment. Common ones that are cited include like orthopedic surgery or even other specialties as well. Do you think that students should really factor this decision, or so factor this into their decision to choose a specialty, and how should they do this?
Yeah, so my advice, because I was the same way, like first, like I think I was even more behind than a lot of my classmates because I had to learn what's some of the specialties, like that there are certain specialties that existed. So it's like trying to figure out what specialties exist when you didn't even know that, like it's like trying to figure out stuff you don't even know, right? So I think the overall way to think about it is in any career, there are jobs that I classify as permissive jobs, and then there are jobs that I classify as restrictive jobs. So permissive jobs, or even you can think about permissive specialties, are specialties that, allow you to be flexible. Like you don't have to come to work between these hours. You don't have to work only in these centers or these locations. You don't have to work at you don't have to do like certain master's degrees or PhDs in order to get the job, right? So these might be more permissive when it comes to time, geography, demand, for instance, the supply and demand. And then there are also jobs out there that are restrictive. And this doesn't just apply to medical specialties. This could apply to any job. Restrictive jobs might restrict you in terms of, geographic location, maybe the availability of the jobs, like there might not be very many positions open. They might be restrictive in the hours, like, for example, if you're operating in the OR, it might just only be open at this time to this time. So you're kind of restricted to these particular hours. If you're doing call, maybe you're restricted to having to do call at these certain time intervals, right? So I would consider those maybe restrictive jobs. And so when I kind of made the decision to choose family medicine, I classified family medicine as a permissive specialty because you can work whenever you want, wherever you want. And you can, choose to do comprehensive family medicine, or you could choose to do other things like emergency, palliative care, addiction, for example. So that was a big factor for me because I knew that, I wanted to be able to choose the geographic location because I wanted my family to be close by, like my family's from Toronto. I wanted to have that support with me. And I also wanted a job where, like a residency where when I graduated, it would be easy for me to work anywhere, right? I don't have to worry about, oh, okay, well, if I can't find a job in this geographic location, then I have to move my whole family to go somewhere else. I wanted to be able to, if I don't want to work nights, I don't want to work on long weekends. Like right now, it's a long weekend and I'm not working, right? So it gives me the flexibility to do things like this, like chat with you guys on the podcast. So that was a big factor for me. So I think if you're a student and you're trying to figure it out, maybe don't try to figure out like, oh, like what specialty should I go into? Maybe everything that you shadow, every specialty that you do, every elective that you do, think about it in terms of, is this permissive and is this restrictive? And how much restriction am I able to tolerate? So for example, if you're going into something where that doesn't have a job, where there's only certain centers that might have maybe the equipment, the support staff, and you can only work in those centers, think about, is that like a restriction I'm willing to accept? Is my family willing to upend their life and move to a certain area where there is that geographic restriction? Am I able to tolerate a restriction like time restriction where, like, am I okay with having to work on some weekends or work on some evenings to still do call as a staff position, for example? So those are all very person dependent, and you have to think for yourself, how much restriction you're willing to take versus how much permission you would prefer to have. So if you think about it in terms of that balance, that might help you decide which specialty you want to go into.
Yeah, thank you. Those are really good points for picking a specialty. I think that's one of the hardest things that you need to get through in medical school. I think another aspect is you get a lot of opportunities to be able to apply to scholarships. So I'm wondering if you have any just go-to strategies that you've used when applying to these scholarships in medical school or even in university.
Yeah, I think probably my biggest tip is if you can go for like a bunch of smaller scholarships than the big ones, you might actually do better and have a higher chance of getting them. Because I know there are some bigger scholarships out there that might require you to put in like a written essays. You have to do interviews. Sometimes you have to travel for interviews. And that can be really competitive. Like there'll be a lot more people going for them. But yes, they are also worth more. But if you put your time, like maybe the same amount of effort and time into applying for several smaller ones, you might actually end up getting the same monetary amount, but with higher chances of getting them. So I think when I was looking up scholarships, I would look up each university's individual scholarship portal to see what I could apply for. I would also look up this website. I think it's still called scholarships.ca. And there were even the forums where people talked about different scholarships. I would also suggest meeting with the financial aid officer in your school because they also have access to the new scholarships that are coming in. So the other thing I would also mention is applying for scholarships is very worth it because say you work on an essay for a scholarship for 1 hour, or you work on a grant for OSAP, for example, and it takes you about an hour. That hour translates into, let's say, like $7,000 in grant money or in scholarship money. There's no job out there where you work 1 hour and you get $7,000 like for students. So plus it's when you get the scholarship money, you're not like taxed on that money, right? Because it's a scholarship for you. So it's actually very worth it if you just target several smaller ones and try to apply for a lot of those smaller scholarships as well.
Yeah, that's a really great point. That's interesting because we just got an email about scholarships and one's like $18,000 and then there's three $5,000 ones. So it really makes sense what you're saying.
Yeah.
I'll definitely apply that. And I think scholarships play like a really important role in med school because like as everyone knows, med school is really expensive. It's like $25,000 every
Yeah.
single year. And that's on the cheaper side, actually. I have friends in the US who are paying $100,000 every single year.
Yeah, that
So
sounds about right.
yeah, So it just keeps going higher and higher every single year. So I think this brings us to a question. I guess it's a little bit more philosophical. But why do you think medical school is this expensive? Because as you talked about, in residence, you're not getting paid that much. Even as a staff per hour, you're not getting paid that much, but you have to invest a lot early on. So why do you think this is?
Yeah, it just comes down to like basic economics, right? Like the principle of supply and demand. When you have high demand and then low supply, the prices rise, right? It's just like how we saw in the pandemic with like toilet paper. It just went up because everyone wanted to hoard it. And so I think the other aspect of why, in addition to the supply and demand, like I think, the cost of medicine is high because when you look at things like exams, for example, like the MCAT, there is only one like group, one organization, the AFMC, I think, or sorry, no, the AAMC that administers the MCAT. It's not like a competitive free market out there, right? So when you look at the costs of applying to medical school, like, yeah, so even with like licensing bodies, like the Medical Council of Canada, they're the only administrator of the licensing exam. There's only one that does it, right? There's only one that does the MCAT. It's not like you can substitute multiple things, like multiple exams to apply to medical school, right? So there are some medical schools that are kind of recognizing this and they're allowing people to apply without having the MCAT because the cost of it can be a barrier for a lot of students who come from low income backgrounds. And without that competition in suppliers, of course, like you can set whatever price you want for the MCAT, and there will always be people who pay it because it's mandatory. So really, you have to kind of look at it, if you make certain things less like not mandatory, like if you just get rid of the MCAT altogether, for instance, maybe that might potentially drive down the costs as well. Just like how, maybe with the licensing exams too, right? There's only one administrator of the licensing exam. There's no competition, so of course they can charge whatever they want. So it's kind of also, it's such a big question to answer because you said it was very philosophical, but at the root of it, I think that is probably why the cost of it is very high. Not enough medical school, lots of applicants.
So now switching from the more philosophical approach to more, I guess, practical tips. Now that we've discussed like why the cost of medical school is so high, can we sort of talk about some ways in which residents, PGY ones or even end of medical school, like fourth year medical students, how can these students sort of cover their debt for medical school? Because for me, I'm looking at this as a first year medical student, and I'm looking at sort of the monthly bills I'm getting from my credit cards, and living in Toronto is very expensive. And sometimes those numbers can be really alarming. So I'm sort of thinking about it for a couple of years from now, and how am I going to be able to manage that debt? So I think for those people that are already at that stage, what would you suggest to them?
Yeah, and there's many different levers that you can push in order to try to find a way to manage your debt. So let's say you're a medical student and you're undecided about the specialty. And for you, being able to pay off a debt is an important factor for you. So you might want to look at more permissive specialties because one of the biggest costs you might face, in addition to your interest on your debt, might be cost of living. So if, let's say, this particular specialty only exists in high cost of living areas like Vancouver, Toronto, Ottawa, then that might be another restriction on your ability to pay off debt, because then you might be paying higher rent as well, and more of your resident salary is going towards that. You can also make the choice to choose a specialty that is in a rural area, because there are specialties like, for example, family medicine. They do have loan forgiveness programs that other specialties may not have. So for example, there is the rural loan forgiveness program for family doctors and nurses. And if I can remember correctly, over 5 years, you can get up to $60,000. So for example, each year you spend at least 400 hours in a rural community, either as a resident or as a staff physician. you might be able to get, let's say, like 8,000 for the first year, and then 10,000, and then I think it was like 12,000, and so on, right? So that it could be a way to significantly cut out your federal loans. The other thing you can think about is some people might look into the military program, where, let's say, if you're a student, they might be able to give you like a stipend every year. And then when you graduate, they'll give you a job with the military. Now, maybe the downside of that is there can be restrictions in where you want to live, right? They might say, well, we'll pay you the salary, we will give you some stipends in medical school and residency to help you with your debt. I think some of them will just pay your tuition altogether. Correct me if I'm wrong. If someone is in the military program, they might be able to make a comment or something on this video. And the restriction is you might have to be in certain geographic locations that the military wants you, right? But likewise, it's always a balance. There are also other programs where some residents, maybe in their later years, like for example, let's say you've done your 3 years of internal medicine, so you have that license in internal medicine, or you did your 2 years of family medicine, and now you're in your enhanced skills year in whatever fellowship, right? And you can, now that you have that license, you can moonlight. So some internal medicine residents, they might moonlight and make a staff salary in like rural areas or in some suburban areas where it might be short-staffed. Some family doctors who have their 2 years of family medicine, maybe they're doing their +1 in like hospitalists, for example. Maybe they might moonlight in like a walk-in clinic as well. So that might be a way for senior residents to help cover their debts. And then, of course, there's all those other smaller levers you can push in terms of like, getting housemates or roommates when you're a resident or as a medical student. Some people might choose to live at home with their parents should they have that geographic flexibility, for instance. Some people might have like side jobs in like tutoring as a student, for example, or they might do like work-study programs with their university as a way to make some side income as well, and just to throw it to their debt. And then most importantly, I think all students and residents should file their taxes, because chances are, because maybe you're not making anything as a student, maybe you're making very little as a resident, having that tax return is another chunk of money that you can use to put towards your debt or put towards your TFSA, FHSA, whatever, as well. So there's so many different levers you can kind of push in order to try to find small ways of getting that money in and really tackling that debt as well. So hopefully that answers your question. And maybe some of you might have some experience in what you guys do to really tackle your debt as well as students.
Yeah, I think these are really good tips, and I'm sure we can find more on Breaking Bad Debt on Instagram as well. I want to ask you something that we found and made us really happy, which was the Equity Award. And I was wondering if you could talk more about how it started, how did it feel for you to give back to students, and just the process of it coming about.
Yeah, so the Equity Award, how it's funded or how it started is I started a conference called the Physicians Financial Wellness Conference. So it's the largest conference for physicians and as well as other, I guess, sometimes dentists and allied health might attend as well to learn about personal finance. So we might talk about topics like incorporation, topics like parental leave, negotiating your contract for your job, anything that kind of relates to finance and practice management. And so the proceeds from that conference, the ticket sales, I decided to donate it to start a endowment fund at U of T. And then that endowment fund was what led to the Equity Award. I called it the Equity Award because the word equity means, fairness, but it's also a finance term, like as an investment, as equities, right? And so I thought like that was suitable in really showing that this is an award for students who come from low-income backgrounds, but that doesn't get them down. Like they're a student who, despite being low income themselves, they contribute towards initiatives to equalize the opportunity, to make it fair and level the playing field for other people who might also come from low-income backgrounds as well. So whether they're doing financial literacy initiatives themselves, doing like affording medical school initiatives, advocating to, you know, lower the cost of applications to med school for students, anything like that, you know, makes them eligible for an award like that. So I wanted to just reward a graduating student who has really tried to uplift other students like them as well. So that's basically a gist of what the Equity Award is.
Mhm. And that's very noble of you, Dr. Stephanie. It kind of shows that you were applying for all these scholarships and working as a resident, and then now you're giving back when you do have the resources to do so. And that's rare. That's rare to see. So that's really, really cool that you're doing that. And I wanted to address the point you were saying earlier too, in terms of how like we as students try to mitigate some of the debt we're taking on. I think I think the main thing for this is doing research and finding out information that we don't know, which is why your lectures have been so impactful. And just learning about like TFSAs, about incorporating in the future as doctors. I think it's been so helpful. And one other interesting point I wanted to mention, just so you know, is that you talked about homeless help and how that really impacted you. It's really, I think it's a coincidence, but me, Naman, and Rushal, when we were in our first year, actually started an organization called Blankets for TO, which helps homeless people. So we've had a very similar experience working with underprivileged populations. We've donated over 10,000 items to this day, and it still lives on in 3 other campuses. So it was really cool that we could do this podcast with you and get you to answer all of these burning questions we had.
Yeah, that's a great initiative. I think it's definitely something that really helps people who don't have the privileges that we do.
Yeah, and we've really looked at it like by helping other people, we're really helping ourselves because it just makes us feel so much better when we're doing these things, and it feels like we're working towards a cause, which is just so much better than just doing things for profit. And with all those questions, I think this brings us to the end of this podcast. Thank you so much for coming on. And I'm sure everyone who watches this is going to learn so much from it. And I want them to comment one thing they learned in the comments below. So thank you so much, Dr. Stephanie.
Great. Thank you, everyone.